Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Mirum Pharmaceuticals.
This program is presented by Medscape Education Global.
Hello, I'm Richard Thompson, Professor of Molecular Hepatology at King's College London, working in the Institute of Liver Studies, and Honorary Consultant Paediatric Hepatologist at King's College Hospital in London. So welcome to this program, which is entitled Connecting the Clinical Clues in Alagille Syndrome. So what I'm hoping to get through today is cover the clinical aspects of what constitutes Alagille Syndrome, the clinical features and particularly the symptoms, then focus on the liver disease, because that's the bit that I understand the best, understand what as best we can, what is happening physiologically or pathophysiologically in our patients that have liver disease. Talk a bit about the drugs that are available, some of the previously used drugs and the new IBAT inhibitors that we are now starting to use. And then hopefully give you some idea of what we can expect as we start to use these drugs and what we should be looking out for. So I'll start with Alagille syndrome, which, as I hope everyone knows, is clearly a multi-system disease, and it can present in many different ways. Obviously, we as largely hepatologists will tend to see patients with a liver phenotype, but they often have other features at the outset. And so they usually present to us, usually in the first year of life, with cholestasis. So conjugated hyperbilirubinemia. Often at that stage they don't have the other liver features, the pruritus and the xanthomata, and those come on a little bit later. And obviously, as you know, many of the patients will go on to get progressive liver disease and come to transplantation historically for a variety of reasons, partly because of the severity of the symptoms and the cholestasis and the pruritus and the consequences thereof. But also, and this was something that the Gala study pointed out to us, actually was probably a greater proportion than some of us realized were coming to liver transplantation with end-stage liver disease. So to zoom back out, obviously it is a multi-system disease, and apart from the liver disease, which we'll be talking about mainly today, there are these skeletal abnormalities, often referred to as butterfly vertebrae. I think that's a slight misnomer. I think they have abnormalities of the vertebral body. They don't always have butterfly, but they certainly have notching of the vertebral body seen on an AP X-ray. They have eye abnormalities. It's probably the most common feature, the posterior embryotoxin, although there are other features that you can look for, but that's the easiest, although it needs a slit lamp examination often to see it. They have renal problems and renal tubular acidosis. They have the cardiac problems, which is obviously a major feature, and the most common is the peripheral pulmonary stenosis, and more severe often is the tetralogy of Fallot. And obviously from a liver point of view, the heart is super important because it does impact the liver, and it also impacts on our options because some of the patients have significant liver disease, limiting our ability to use liver transplantation or requiring cardiac intervention before we can think about liver transplantation. The patients often have characteristic facies which may be visible in the parents as well, because we know that 50% of the parents do carry the same variant. The facies are often not that obvious when they present as infants and become more obvious later on. It is a vascular disease, and I think most of the features are related to development of the arterioles and arteries in particular, and in a similar fashion, the bile ducts development in the liver. We classically, in the liver disease, is described as a paucity of the intrahepatic bile ducts, because on normal light histology, that's what we see. We see that not every portal tract has got a bile duct visible in it. Often it needs cytokeratin staining to really be sure about that. And there's been some excellent work recently looking further into that, and it's quite clear that when you do any sort of 3D imaging, you can see that there is a delayed development of the biliary tree. And as the biliary tree develops, actually the loss of development alongside the portal vein radicals is lost, and there is clearly disorganization of the branching of the biliary tree. And I think the consequence of that, and it's still a little difficult to picture this, is that there isn't the same relationship between the canaliculi where bile is formed, which then should drain via the canal of Herring into the smallest bile ducts. And so there's a loss of connection, I believe, between the canaliculi and the bile ducts, meaning that certainly large parts of the liver are draining less effectively. So that is really why I think you have cholestasis. Now, key, obviously, to cholestasis is understanding what it is that we are excreting in bile, what is retained as a consequence, and how that causes liver disease. And I, for a long time, have focused what I believe is the most important component of that, which is bile acids. And I do want to just briefly refresh your memory about how we handle bile acids. And obviously they're synthesized in the liver. We only have to synthesize a relatively small proportion each day, because that should normally equate only to the fecal losses. Bile acids are synthesized in the liver, but they're transported out of hepatocytes into the canaliculi largely by BSEP, the bile salt export pump. And bile acids then flow in bile into the intestine and are used for the absorption of fats and fat-soluble vitamins, but those that are not used are reclaimed in the terminal ileum via the IBAT, the eye-level bile acid transporter, across enterocytes, exported out of the enterocytes into portal blood by ost alpha beta, returning the portal blood to the liver, are taken up by NTCP, transported into the liver and across the liver and out again around the circle. And in healthy people, those bile acids go around that circle 3 or 4 times a day. And as I say, the only de novo synthesized bile acids are the ones that are to compensate for the fecal loss. So in primary cholestasis, and in this I would talk about really diseases where retention of bile acids in the liver is fundamental to the disease process. It is the high concentrations of bile acids in the liver that cause the liver injury. And we now think that it's the high concentrations of bile acids in the liver which are causing the release of other molecules, which in turn cause the pruritus, which obviously is the major clinical manifestation in most of the diseases, and particularly in Alagille syndrome. But there's a second mechanism of cholestasis, at least under that broadest umbrella term, where the main injury is to the bile ducts. And so there isn't a primary problem with transport out of the hepatocytes into bile, but the high concentrations of bile acids are causing injury to the hepatocytes to some extent, because obviously they're being exposed to bile, but also to the cholangiocytes. And the sorts of diseases I'm talking about here are really collectively called cholangiopathies. So the diseases which are associated in my mind with primary cholestasis are not just BSEP, but the other low gamma GT cholestasis such as FIC1 deficiency, TJP2 deficiency, MYO5B, etc. The diseases which we as paediatricians in particular look after that cause cholangiopathies are MDR3, where there's a lack of phospholipid, obviously biliary atresia, but the more adult diseases, PSC, PBC, and a growing group of ciliopathies where, as a result of abnormality of primary cilia, we have abnormalities of bile flow, bile duct development, etc. Now you'll notice on this slide as it stands, I have not put Alagille syndrome on there. Now if we go back to what I was saying about the developmental abnormalities which actually cause Alagille syndrome, I don't think there's a problem with BSEP. I think the problem is further down. But the problem is that really there's not proper continuity between the canaliculi and the bile ducts. So actually they have really a post-canalicular problem, so therefore they will have a secondary cholestasis. So they've got injury to the biliary tree and secondary cholestasis, but because there is a fundamental problem with bile drainage, they often present looking like primary cholestasis, where they've got retention of bile salts, they've got jaundice, they've got liver cell injury right from presentation, even though the problem is actually slightly downstream of the hepatocytes. However, I do believe that because some of the bile acids are being transported, there's bile duct mediated injury after the hepatocyte, but there is definitely bile acid mediated injury as a consequence of retention of bile acids in the liver. And as I've said already, I believe very strongly that it's retention of bile acids in the liver that are causing the pruritus, which is such a major feature of this condition. I simplified that enterohepatic circulation even further into a circle where the liver is represented at the top by a triangle transporting bile acids out of the liver into the bile and then the intestine, the reuptake in the terminal ileum across the enterocytes into portal blood and returning to the liver. And I find that useful because then I can begin to think in my mind about where abnormalities occur. And in primary cholestasis, where there's a problem with transport of bile acids out of the liver, we get accumulation in the liver, we get a reduction in export from the liver into bile and intestine, and then we get spillover of bile acids into the peripheral circulation. So there's escape from this normal enterohepatic circulation into the peripheral circulation, actually because the liver is protecting itself. It's not taking up all the bile acids being presented in portal blood. Now, clinically, this is super important because that's actually where we measure bile acids on a day-to-day basis and in clinic. We don't measure them at any other point in the enterohepatic circulation. So that is the position our patients are in. They've got retention of bile acids in the liver, they've got increased concentrations in the peripheral circulation, they've got liver injury as a consequence, they've got pruritus as a consequence, they've also got fat and fat-soluble vitamin malabsorption as a consequence of having low concentrations of bile acids in the intestine. Now, historically, the majority of our treatment has been aimed in a very supportive fashion and largely nutrition, optimizing fat absorption with MCT supplementation, optimizing vitamin supplementation, often orally, but in many cases we've had to resort to intramuscular injections to support them where they've really had major problems. That's been the mainstay of our supportive management. But of course, the pruritus is the one that they come to clinic complaining about, quite rightly, because it's disturbing their daytime life, but probably more importantly, the sleep of the patient and their relatives. So we've used in the past a whole range of treatments to try and address pruritus. UDCA, ursodeoxycholic acid, is prescribed hugely in pediatric hepatology. It is a slightly more hydrophilic bile acid than the ones we make ourselves, but it's no magic cure for this disease. But I would advise against using high doses because it is a bile acid and retention of UDCA is going to cause potentially more liver injury. So modest doses of UDCA are probably still going to be widely used. We have tried to interrupt the enterohepatic circulation of bile acids in the past pharmacologically by using bile acid binding resins such as cholestyramine, cholesavolame, with fairly limited effect. I think they're just not very efficient, cholestyramine in particular. So they have been used. They are difficult to use, of course, because they also interfere with the absorption of fat-soluble vitamins in particular. In addition to that, we've used a whole range of drugs which we don't think have got minimal, if any, effects on the liver disease or the pathophysiology, but we're just trying to treat the symptoms of pruritus. And in that respect, we've used ondansetron, we've used sertraline, we've used naltrexone and other opiate antagonists to try and manage it just as you would use a painkiller to treat a headache, not to treat the underlying disease. And as we all know, they have some benefit in some patients, but not anything like what we would like to achieve and what the families need. Now, we've used rifampicin, which may be having some benefit in terms of its action in the liver and its working on nuclear receptors in the liver. It may change the conjugation pattern slightly. It may increase some of the transporters into the biliary tree. Really, not many patients have derived much benefit from it, but it hasn't stopped people trying that as well. So that's a long list of drugs. When we've used various combinations of those with fairly poor results, which is why we need something else. Now, in PFIC in particular, we have used a surgical interruption of the enterohepatic circulation much more than has been used in Alagille syndrome. And I'm not really sure whether that's because it's less effective in Alagille syndrome or whether it really has not been tried extensively. Certainly our own experience is small and disappointing. The majority of the treatments that have been used are the partial external biliary diversion, but also ideal exclusion and, in a few cases, anastomoses between the biliary tree and the transverse colon. And in the more intermittent forms and as a temporary measure, people have used nasobiliary drainage. So all these surgical or at least mechanical procedures are designed to interrupt the enterohepatic circulation and divert bile acids out of the body, whether it's through a stoma or into the feces or even into a nasal drainage bag, to reduce the circulating pool of bile acids, in particular to reduce the concentrations of bile acids returning to the liver in portal blood, and therefore to reduce the requirement for the liver to transport bile acids. And if we can get down into the sort of range that the liver is capable of transporting bile acids, if we can get down into that range in what we're asking the liver to do, then we won't have the same problem with accumulation of bile acids in the liver, and we won't have the consequences of that liver injury and the pruritus. So it's on the background of those previous attempts to use mechanical interruption of the enterohepatic circulation that we now have turned to the IBAT inhibitors. So we are exploiting the fact that there is a single molecule responsible for harvesting bile acids which are still in the terminal ileum and recirculating them back to the liver. So what we can do now is we've got a number of drugs which are investigated and some of them licensed for blocking this transporter in the terminal ileum. And what we will do when we do that is we will increase the fecal loss of bile acids. We will undoubtedly increase the de novo synthesis of bile acids, but we hopefully achieve a new steady state where by continued blockade, we have a increased excretion of bile acids into the colon. We have a slightly increased synthesis of bile acids in the hepatocyte, but they are equal. And we have, most importantly, reduced recirculation of bile acids via the portal blood to the liver. And therefore, we have a reduced requirement for the liver to transport bile acids and a reduced retention of bile acids in the liver. by using this pharmacological interruption of the enterohepatic circulation. And as you know, we have there's been a number of randomized clinical trials now. Firstly, with maralixibat, with some randomized placebo-controlled trials and a withdrawal study, and more recently, odevixibat has been used in a conventional randomized placebo-controlled trial. So the clinical trials data that we have so far do clearly show we've got an improvement in pruritus, which is much greater in the treated group. We've got clear evidence that serum bile acid reduction is much greater in the patients treated with IBAT inhibitors. So how are we going to use these drugs? So I think most of us still, when we first see patients, whether they've got PFIC or Alagille syndrome, we are still going to start off by doing the simple things and low dose ursodeoxycholic acid. In many cases, we will add rifampicin when we first see them, maybe until we get a diagnosis. But more importantly, till we get a feel for how cholestatic the patient is. We haven't got any way of predicting the degree of cholestasis. The genetics of Alagille syndrome are extremely helpful in making a diagnosis and explaining the problem to the families, and they're very useful in counselling families about future pregnancies, etc. But they're actually not useful in terms of any prediction as to the severity of the disease. So we do have to individualize our therapy, and I would escalate, as I say, using small doses of rifampicin, and then if it's persistent and it's usually towards the end of the first year of life that we realise that we have enough sufficient problems that we're going to have to escalate, then I would start introducing an IBAT inhibitor. Then, of course, we've got to try and decide whether we've gained an adequate response, and it may be that we need to increase the doses, and certainly some of the early studies with these drugs we underdosed, and we've had to escalate the dose to get enough effect. But of course, what we're hoping for in the first instance is a biological effect. So reducing serum bile acids is a very encouraging biological sign that we've had a benefit. But again, what the patients want to see is the pruritus improving. Of course, in clinical trials, we've used a whole lot of scoring systems, and some people still do use visual analog scoring systems, etc. To be honest, I asked them about their quality of life and the quality of sleep and how much it's interfering with daily life, because those are actually what people care about. And I think recording that, you can get an idea of whether we're making progress, whether we do need to consider other drugs, whether we need to increase the dose, or ultimately whether we have to accept that we have failed to get an adequate response. And this is quite difficult territory. And obviously what we have got is the data from clinical trials. And these are obviously in a very controlled circumstance. We've got the initial randomized phase, we've got extension studies. Those patients are being managed in a slightly different way. They're also patients that met the recruitment criteria, which are designed to be fairly representative of the patients we see, but they're not the very youngest patients, which may be the most severe. They're not the patients, some of the patients maybe had relapsing symptoms and they wouldn't have made it to the clinical trials either. So we still need a lot more data. And there are longitudinal studies which will be undertaken in North America and in Europe, which will hopefully capture some of that data and give us better evidence of how we use these drugs. But I would strongly urge, once you've got someone that's got persistent cholestasis and you've failed with the very simplest measures, that we think very hard about using an IBAT inhibitor on top. Then look for the same clinical features about when you're going to stop using these and when you're going to stop using the other drugs and potentially getting off rifampicin and if you're using it, naltrexone, etc. I think probably keeping a small dose of ursodeoxycholic acid going is probably a good idea, because there is a downstream injury. Even if we stop the problem of accumulation of bile acids in the hepatocyte, there is an abnormality of the biliary tree. And I think maintaining a hydrophilic bile composition as much as we can with small doses of urso in the long term is probably beneficial in Alagille syndrome. Now, the data we have from those clinical trials, we have put those together and looked at some of the long-term consequences, and they are encouraging so far. And the data, I hope you've seen a recent publication where we put together the 3 studies of maralixibat usage, and we looked in the longer term, and we looked at the predictors of native liver survival at 6 years based on the response after 48 weeks. And it's not too surprising. If they improve their pruritus, then they improve their native liver survival. If they improve their serum bilirubin levels, then they improve their native liver survival at 6 years. If you improve their serum bile acids, then you improve native liver survival at 6 years. If you combine those things together, then if you achieve all 3 of those endpoints, you reduce all 3, then you can, in those follow-up study, there's 97% of patients were transplant-free at 6 years. On the other hand, if you fail to make those 3 criteria, the transplant-free survival at 6 years was 33%. We do, in the short term, have increased native liver survival, avoidance of liver transplantation. I think it's important to remember, though, that many of the patients coming to liver transplant, one of the main drivers is pruritus. And it remains to be seen whether we have truly changed the natural history of the liver disease, or we have just improved the cholestasis enough to avoid pruritus being the driver of transplantation. So I think this is, we use the drugs, we see what the response is, and then we can try and give the families some indication of what the future might look like, depending on those simple responses. Clearly, we hope that by reducing the concentrations of bile acids in the hepatocyte, we have reduced the liver injury. But that is not proven yet, and that remains to be seen. So I hope I've given you a little bit of insight into what I think are the pathophysiological mechanisms underlying Alagille syndrome, how abnormalities of the biliary tree, how failure of drainage of bile from candiliculae are causing bile duct injury, poor drainage, but most importantly, retention of bile acids in the liver, consequence, liver injury, the pruritus, and the overflow of bile acids in the peripheral circulation, which is what we measure in clinical practice. We still need to learn a lot more about how to use these drugs properly, but it is without any question a huge addition to our armamentarium for treating the liver disease of Alagille syndrome. Thank you very much for participating, and do continue after this to answer the questions and complete the evaluation.
This program was presented by Medscape Education Global.